the experience I gained training, the medical training in Cuba, I wouldn't trade it for the world. The exposure. Cuba was like the United Nations of medicine. You got students from everywhere, including the US. So the multiculturalism that was there. One, our medical thinking when we come back is in Spanish. Medical thinking, you would know this. Because, I mean, your medical thinking is in English. It's not in Zulu.
Yes.
But you have to translate from English to Zulu. So our medical thinking was in Spanish. Secondly, the disease profile. I went through the whole medical training in Cuba and I saw one HIV patient. One HIV patient.
Doc, you mentioned something that I want to go back badly. Health care should not be negotiable. I think we should come up with a system in South Africa that obviously involves politicians because they're part of government. And the conglomerates and the big pharma. I say, look, you are in South Africa. You can't take the model that works in the UK, India, or somewhere else. This is our situation. But the government should be seen to be doing better. Because at this point in time, even if I have that dollar, it's very difficult to put it into the government because I don't know where it's going.
They give you the health system of the country. As a student, you will need to understand the health system that you're going to work in. They teach you from year one in medicine to your final year there in Cuba, the importance of preventive medicine. And that primary health care is not a clinic. It starts with the lifestyle. There's something called health situational analysis, or what they call community diagnosis.
Welcome to, once again, I'm with Mr. Mpumulo, Creative Replay. He's a guy that makes it all happen. This is Rhythm Unplugged. We are extremely fortunate. I know most of the time people always say these things that we're fortunate, but I was taken aback when I got a call from Vezi that I should have an interaction. I know it's just more of a dialogue more than anything else with this esteemed young man. So today we have a very complex person, a CEO of South African Medical Association, a trade unionist. I'm not sure if it's been called that, but I think you are a trade unionist, and an academic, someone who's a physician, someone who also holds degree in public health management. This is Dr. Mzungile Notikita. I've been wanting to make sure that I got that right.
Notikita, yes.
Did I get it right?
Yes, perfect.
There may be some differences, Eastern Cape going to KZN. So Dr. Mzulungile Notikita is here with us. So hopefully we will be able to unpack a lot of stuff. Some of it, as the interviews goes, is very personal to me. Right, as a doctor in South Africa. So Dr. Mzulungile Notikita, a CEO of South African Medical Association. Welcome.
Thank you so much, Dr. Vezi. Very strange that you have the surname of, which is the name of our head of corporate affairs. But no, I'm excited and looking forward to interact with you as well.
Yeah, so the background, of course, Dr. Notikita is a doctor, he's a medical doctor. He is, like I said, I want to put emphasis on trade unionists because you're running this conglomerate of organization that looks into advocacy for the healthcare workers, not just doctors, I assume, but most of us in this field. We have challenges in this country.
Yeah, we do.
We have challenges. Your pillars of this organization, if I may summarize it, obviously I'd like you to go into detail about it, is advocacy. And talking to the healthcare workers, talking to the healthcare providers to make the situation of the healthcare system more attainable, more workable, but also you are extremely important in terms of ethics and professionalism. Doctors should be held accountable. I'm just going to go straight into private doctors. Where I'm also in private sector, we feel that you can act with impunity where there are no consequences. I'd like you to get into that later on. But the biggest thing, tell us about yourself.
So I think before we go there, let's just frame the purpose of existence of SAMA. So SAMA is the South African Medical Association, right? And it's a national medical association. Almost every country has got its own national medical association. And let me just take a step back about how it came about. So before 1994, there were racially divided medical associations.
I remember those days.
Yeah, and these came together. So what happened at the country level, the de Klerk Mandela negotiation thing, it happened at the medical level as well. So there are two guys who came together and they dreamt of this United Doctors National Medical Association. So that's Dr. Mlisana and a certain guy called Dr. Hennico. So in 1998, they then amalgamated all these separate, racially divided national associations, and they made SAMA. But SAMA kept the registration number of NAMDA, which was the National Medical Association of South Africa then. It was registered way back in 1927.
Okay.
So SAMA inherited that registration number. So next year, SAMA will be celebrating a centenary.
Oh, okay.
So I thought I should bring that in. Away from trade unionism in its traditional sense, because we believe at SAMA that doctors, because of their ethical responsibility, they are almost like a square in a round within the traditional sense of trade unionism. So I thought those are important just for us to have an understanding of the organization itself. But I was born in a small town called Pedi in the Eastern Cape, a rural village called...
You didn't speak Pedi though?
No. So the town is called Pedi in English. That's Peddei. But in Xhosa, kusengqushwa.
Osengqushwa.
Yes. And my village is called Bell, but in Xhosa it's called Etuwa.
Etuwa.
Yeah, so there were some German nationals who lived in that area in the past. It's the coastal side of the Eastern Cape. So I grew up there. I went to school there in Bell, moved to stay with my utatomncinci. How do you say utatomncinci in English?
Oh, yeah. It's your uncle.
Yes.
Yeah.
So I moved to stay with utatomncinci in town, in that small town of Pedi. And they matriculated in 1999 in one of the oldest schools there called Nathaniel Pamela. Now, then interesting things started to happen because I did well in my matric, fairly well, but we didn't have the money to take me to school. And I wanted at that time to do information systems, a BSc in information system. And
That was your goal?
Yes.
As a matriculant?
Yes, and I wanted to do it at Rhodes University. Like, I didn't want to go anywhere else. So I went to Rhodes, but I didn't have two critical things that were needed for admission at that time at Rhodes. One was that you get preference if you are from one of the coded schools in Grahamstown. Grahamstown has got one of the best schools in South Africa. They are coded, they've got codes. And then you needed to do well in Afrikaans. And even though I did my matric very well, Afrikaans was the worst.
Yeah.
So they told me.
It's not going to happen.
It's not going to happen.
So when you say code, so these schools are graded in terms of how good you are?
Yes.
Oh, okay, all right.
And so the universities got the numbers of the school, the codes of the school. So when you say, I'm from Nathaniel Pamela, they put that in, and if it doesn't show, they're like, no.
Didn't have like a quota system that maybe we should be inclusive of everyone? Of course, maybe we'll take 85% of these and 15% of the non-coded schools or less coded schools.
Well, I wouldn't really know the details. I was young at that time, but I also think it was the transition period, because this was actually in 2000.
Okay.
Yeah. So then they told me that I needed to go and do some computer literacy and come back to them, improve my Afrikaans and come back to them in 2001. But then the I think I was in church when the scholarship for Cuba was presented to me by a church elder. And the church elder was telling me, no, but I heard that you did well in your matric and you don't seem to be in varsity. What's wrong? I said, I don't have the money to go. And the university I've applied in, they want Afrikaans, I don't have. They want computer skills, I didn't get in matric. So then the person shared the scholarship for Cuba. I applied, but I was late for that year, so I couldn't go. I had to wait for, I think, 2002 cohort, but we left the country in 2001.
Quick pause, guys. Today, the whole podcast is totally sponsored by Creative Replay. You know who they are, Mawanda, Mapumola, Mashimane. So we've been together, probably going to be closing on a year. When I first started on this journey, I thought I could make it. And all my colleagues are asking me, who's doing that work for you? For two reasons. One is the quality that they bring into the podcast, and two, professionalism. So I don't have time to be doing this all by myself. I do joke about it and say I'm doing it, but Creative Replay has been behind this wonderful, relatively short journey, but very, very meaningful. So they take away all the stressor of doing something like this, because I'm really passionate about impacting knowledge and my experiences, and Creative Replay makes it easy for me to manage my time and to engage with you as a family. Thank you very much once again, Creative Replay, for doing all what you've done for me. Big up. So that transition, was it kind of like big because you set your mind on something else and suddenly you find yourself like a lot of Black students, unfortunately. I was in a similar situation when I couldn't go to school. So that resonates with me. But I always wanted to do medicine. So now you have to leave home. You have to probably learn Spanish.
Yeah.
You're doing what was not your first choice. How did you feel about that?
Yeah, so I was very disappointed at Rhodes. So let me put that out there. Very, very disappointed. But I had a grandmother who believed that almost everything happens for a particular reason. So between Rhodes and Cuba, I also had an opportunity to become a pilot.
Oh, okay.
Yeah. So
how did we miss that?
I was actually shortlisted. Now I'm reminded because the grandmother refused to sign the papers for the pilot
training.
She literally refused and said, I'm not doing that. Because I can't for the life of me imagine that whatever flies here, you will be there. No, that's not happening.
Yeah.
And I know you want to be at Rhodes, it's not happening, but there's a purpose behind this.
And you're not going to be a pilot either.
And you're not going to be a pilot either. I was a bit frustrated with her, I must be honest, frustrated with Rose and with her. But when this opportunity came, and I must say, during that time, I had also just lost my grandfather. And I kind of took care of my grandfather during that time. So this medicine thing sounded kind of something that could work.
Might come in handy.
Yeah. And you could make an impact. There was something there that was saying you could make an impact. But the information system thing was really about the .com thing. So when I was weighing the two things, I was like, okay. And now I'm going to a strange country. I was like, okay, let's go. Let's see how is this going to work out. And I can tell you, Doc, that experience, the experience I gained training, the medical training in Cuba, I wouldn't trade it for the world. The exposure, Cuba was like the United Nations of medicine. You got students from everywhere, including the US, which is very strange, including the United States of America. So the multiculturalism that was there, also just the opportunity to compare your country, what you refer to as Bantu education, with how you perform with in a global community, that was mind-blowing.
I can imagine. I mean, one of the biggest things that young people or a certain sector of people are always afraid of is the fear of the unknown. And it holds a lot of people back. So the word exposure for me has always been one of the biggest things because, you always think sometimes you're in the worst possible situation until you see other people and say, well, it's not so bad.
Yeah.
Or you're on your high horse, you think nothing is better than me, and then you go there.
You realize.
Yeah. So someone like me who's never been to Cuba, for instance, now I'm getting educated. It wasn't just South Africans going there because of partnership between these two countries, but even the countries that are perceived as foes, enemies, Americans, maybe Canadians, whatever it is, they were in Cuba, right? So, and people went there for different reasons, but I think the exposure that you got there.
Yep.
But also one of the things that are important to the youth, because one of the things I do this podcast is just impacting knowledge and the possibilities that, if you find yourself in a situation and you get into a cul-de-sac, there are other outlets, there are other pathways, but it takes a lot of guts for you to leave your family. But before we jump into that, because that becomes very pertinent to this interview, you talk about your family, right? I come from a family of, we're 9 at home.
Sure.
5 different mothers. My father is a Rolling Stone.
Yeah.
But you mentioned your parents very little. You mentioned your aunt quite a lot. You mentioned your grandparents. What about your nuclear family?
Sure.
Your support structure.
So I grew up, at some point I believed I was the last born at home, okay? Because I was brought up by grandparents. They played the mother and the father role. My mom, when my mom were 4, so I'm the third of the 4. I've got a younger brother, an older sister, and an older brother. Same with the father. Difficulty here is that my father, between myself and my older brother, my sister has got a different father.
Okay, all right.
And that kind of caused the problem.
Yeah.
But my father still lives and is here in Pretoria. So
it's in Pretoria?
yes, we're actually planning to have coffee together soon.
Oh, that's good. That's good.
But he was not present. And at some point I was angry about it, but I think I've gone past that now because I've kind of forgiven that process between him and my mom. Yeah. Because we can't control those.
Yeah. It's very strange now because that resonates with me. I don't know if I use the word badly because throughout medical school, there's a friend of mine, Trevor, he came from Davidson, I came from Umlazi.
Sure.
And because we were at the University of Natal in Durban, during holidays, because of financial issues, they were like, no, I don't want to go home, but I'd like to maybe stay with you. That period of November, December, you can't stay at the rest. Yeah. And I couldn't take him home because of the complex situation my parents didn't have. We used to go to what's called Pasha, where you rent, and I never knew where will I spend my next Christmas. And I was angry as well.
Yeah.
Was angry at my siblings, was angry at the other wives, partners of my father. And you realize when you get older, it's probably if you have to put one blame is your father. And also, even there, you realize, he was born in a different situation. My father got married at the age of 21. He was a kid, all right, uneducated, in certain circumstances as a black man in South Africa. So for those reasons, personally, I don't know why you forgave your father, and I'm glad you did. Yeah. But those situations, like, I'm not him, and I didn't live his life.
Yeah.
But I just want to touch on that because I realized that your grandparents played a pivotal role.
No, those are, in my world, my parents.
Yeah.
Because they gave me the love, everything. They gave me the nuclear that you were talking about. They gave me that strength.
Yeah.
And the nice thing was that I grew up with my siblings. We were all in the same house. And cousins, what we call cousins, but we call each other brothers. So my mother's sister's kids grew up with me. So we grew up
in a big family.
Yeah. So for me, the person I had the closest bond with, and I can tell you this without any shadow of doubt, this is actually one of my cousins. We competed from primary school with this guy. Remember those days you had the positions in terms of how good
you'll be at the end of the year, we'll be on the lawn, and then number 1 is so-and-so, number 2 so-and-so, exactly. And your heart will be beating faster because you don't know if you're going to make the cut.
So So this guy, his name is Netema, but he passed away in 2000. Yeah. He was 2 years younger than me, and he was a great lawyer. So he told me that, look, if you slip, I'm catching up with you.
Yeah.
And we had a bet that you can't fall outside of top 5.
Yeah.
You must be number 1, or we accept that there can only be 4 people in front of you.
Yeah.
So that was the competition. And I think when we changed schools, because we actually changed schools when I think that was standard 2, and then I had to go to standard 3 with him in the same school. So when we got there, the league was different. I think the first exams we wrote, which was mid-year exam, I was number 21.
Way off the pack.
And this guy was number 1.
Oh,
I was like,
in his grade?
In his grade was number 1. I was like, you see, you want to sleep.
What happened? What made that bad transition?
Look, I think the levels of the schools. I'll be honest with you. I think the schools were different. But I catched up. I mean, by the time we were writing the final exam the same year, I was number 3.
Great.
The next year...
What is it that you did, sorry to interject, what is it that you did differently? And once again, I hate to compare myself to Dog. My stories and this young man just overlap at so many levels. But this is a critical personal question.
Sure.
What is it that you did differently to move from number 21 to number
3.
Number 3.
At the end of the
That's a quantum leap success.
So I had a conversation with him, the younger guy. He said, dude, but firstly, you can't be like, what is this? You can't be, how many, 20 people in front of you? This is not you. So paying attention when you are being taught as a young kid was a problem for me. But then I decided, okay, maybe the first few minutes, let me pay attention. Once I grasp whatever they're telling me, then I'm gone. I would lose. If you repeat the same thing over and over again, I'll be done with you. Yeah. So, but then I said to myself, okay, maybe let me listen a little bit. Let me give them maybe some time, and then stop listening. And then whatever they've taught me, I'll practice with it when we get home.
Yeah.
That, okay, this is what we're talking about. We would actually narrate the cities of the world. Starting from Africa, what's the capital of Zambia, what's this? We would play with whatever we've learned in school. So that helped, but I didn't know that it was working, because whenever they asked the question, it's what we were talking about at home. Yeah. So that worked, but it put me in hot waters, because the following year, the teacher would only tolerate me for the first few minutes as well, and then said, you're starting to just leave my class.
What is it that you did to irk your sister, your teacher, to say leave the class? Too many questions?
Something else. And playing...
Turbulence in the class?
Playing with the person next to me.
Oh, okay.
In fact, the lady who was sitting next to me was almost the same, because she would also just get bored after.
Maybe you guys are just a bit above average for whatever you're getting taught.
I don't know. Yeah. But I think it worked out, because throughout that time, I mean, I was never outside the top 5. At least that I tapped it to my brother until... Yeah.
Once again, I just want to come up to a certain nuance that you mentioned, because I like it. So you basically decided that you want to change something about your life. But it wasn't just feeling sorry for yourself. You put time. So when I was growing up, Umlazi, what we did with my friends, like you did with your cousin, was to go to school 2 hours early.
Yeah.
We were also very fortunate at the time, and I want to talk to you about this later on when you talk about healthcare system partnerships.
Sure.
To date, I almost always go to Shell garage to fill up, because Shell then had, they administered tests, and then the top 15 students at the Umlazi will then get scholarships to be within the township, but bring in good teachers from outside.
Nice.
So that partnership for me worked. But I think at the core of my own success, and probably your success as well, you put in time. Because you often hear people, the school isn't working, which is true, but what is it that you're going to do differently? Yeah. You can't be sitting here and complain about the system, but you're not doing anything differently. So you put in more time, and you move from 21 to number 3, and you never went outside what you wanted. So that was your background.
Yeah.
And the Cuba one is very important to me because we have this thing painted in our brains as those who didn't go to Cuba that
Sure.
these are the students who couldn't make it in South Africa, right? And therefore they go there, and usually they are people of color, right? But from what you're telling me, and my legal experience outside South Africa is, it was something like you wouldn't trade off for nothing.
Yeah. No.
Because of the culture, because of the system.
Doc, so the first thing is, you get there, it's a whole new world, completely different from whatever you know. The weather is just wrong. It's hot throughout the year. Everything, what they eat, everything is just completely different. Okay.
They have to adjust.
Yeah, they speak a language, you have to point. I make the joke in one of the interactions I had with, I think it was Bekisisa, like I was saying. We couldn't even buy something to drink.
You have to point.
Yeah, we have to point. And you have to ask your English teacher, what is a Coke? They say it's a cola. You run down, you're like, oh, what did they say? And then you get there, you say cola, they say kwal, you're like, kwal. What is kwal? They're actually asking you which one.
Oh, okay.
But now when they say kwal, you like, you need to run upstairs.
And ask what kwal is.
So kwal is
Those
like,
are the challenges that you have to face.
Yeah. So that's learning Spanish, that process of learning Spanish alone and being introduced to medicine in Spanish was mind-blowing. But I think for me, the approach of the Cubans to training, firstly, in Cuba, I discovered this later. I didn't know that that's how it worked. You don't, by virtue of being a doctor, then you can train people. You need to be trained in pedagogy to actually be.
What is pedagogy?
That's they call it maestria in training. So pedagogy is actually, they teach you how to teach.
Okay, which I think is important.
Yeah, with your medical training, but then you must know how to teach people, how to transfer knowledge.
I think, sorry, I like talking. So when I grew up, I worked at a place like King Edward and all those places. And then they used to be called, not the CEO of the hospital, superintendent.
Superintendent.
And realized some of these hospitals were mismanaged because they've just taken maybe the most senior doctor or maybe the most intelligent doctor to manage the hospital, which is different. But with this concept, that yes, you're a doctor, but you're not a manager.
You're not a manager.
For you to, even within your field of medicine, you need to be taught how to teach.
Skills.
Because that's a skill you don't have. And this is something that we take for granted, even in this country of ours, right?
Doc,
a beautiful concept.
They give you the health system of the country. As a student, you will need to understand the health system that you're going to work in. They teach you from year 1 in medicine to your final year there in Cuba, the importance of preventive medicine. And that primary health care is not a clinic. It starts with the lifestyle. There's something called health situational analysis, or what they call community diagnosis. As a student, you are allocated 25 families, and you must go stratify those families. You look inside the family and group each and every member of the family, whether they are supposedly well or they are supposedly well with the risk factors. Are they on medication? Do they have complications? You've got about 5 groups where you put, and you must go and present. That's your work as a first-year student. When you are in final year, you need to go back to that community and see what the interventions that you and your doctor, the community doctor, that you put in place that time when you were studying in first year. What impact have you made to those families?
So it's a research right from the beginning, but that is a very impactful. It's not just something on paper. It's something that translates to health. Because I'm a cardiologist. I'm super, super specialized, but I always tell people, and this is not a lip service, that yes, my work is important, brings me money, brings me lifestyle, but it's all about child health care, maternity,
Yes.
antenatal clinics,
Yes.
feeding programs,
Yes.
like you say, lifestyle. We had a similar subject called community health, but it was not
Yeah.
as detailed. So community health, just a bit, was for us to also engage in families. It was mainly pediatric and child health care. But it also taught me that don't be judgmental to the patient when they keep coming back with the same disease. Like you said, you are taught to be a doctor, but you don't understand the basic things that if this person goes back to the same community without any intervention, why are you surprised when they come back with the same?
Back.
Right.
So for me, I think I think the primary healthcare approach in Cuba was important. The exposure to the multicultural nations that were there. I mean, we spent a lot of time trying to understand how Asians celebrate their national days. But the Latin Americans, the culture in Latin America is crazy. The islands there, those Caribbean islands, on the Jamaican national day, it's crazy. On the South African national day, it's just...
It's a pride day.
So for me, it's a pride day for South Africa.
Yeah.
So I think for me, the Cuban
national
experience... I mean, let alone the fact that we've learned quite a lot of... we say it ourselves that medicine is probably the last degree you want to study outside of your country, simply because of the disease profile. And I think that's the transition that might make people think that these guys are not, they don't know what they're doing. So I'll give you 2 examples. One, our medical thinking when we come back is in Spanish. Medical thinking, you would know this. Because, your medical thinking is in English. It's not in Zulu.
Yes.
But you have to translate from English to Zulu. So our medical thinking was in Spanish. Secondly, the disease profile. I went through the whole medical training in Cuba and I saw one HIV patient. One HIV patient. The South African government had to come in when we were doing 3rd year to negotiate with the Cubans, because in Cuba, a pregnant woman cannot be operated by a junior. There must be a specialist obstetrician. There must be a senior registrar who's assisting. The students are down there
just observing.
You can't touch the patient. So the government of South Africa had to talk to the Cuban government. We were given papers that when they go back to South Africa, they will be the first and the last line of defense. So let them cut. And the Cuban made exceptions for South Africans. So we were allowed to cut. And some of the students from other countries were not happy because South Africa, because of the paper, yes, we were now
negotiations
allowed.
had to come into.
Yeah.
So you talk about transition. Now, coming back to South Africa, what's the biggest downfall of our system? We love our country, no doubt about it, but we'll catch up on that. Our system is failing. Right, and failing badly. And it's getting worse. So the transition, how was it for you, besides Spanish, besides thinking in Spanish, besides the major differences, how you approach healthcare and coming here? Obviously excited to come more, but what was the major mind-blowing changes that you had to face and you didn't like?
Look, I think for me, it's the curative approach to healthcare. I think South Africa, it makes healthcare expensive because we, as a country, kind of wait for people to get sick. And even when we try to solve their problems when they are sick, like you're saying, they go back to the same communities, and it's a problem. So let's just talk about maternal care, for example. Just make an example there. If I was in the Ministry of Health, and I say this even to the minister when I get the chance, I would focus on primary health care, specifically for maternal care, and early capturing of the pregnancy itself. So you educate people so that pregnancy is actually planned. It's not something that just happens. Because the first 1,000 days of life are critical in any person's life. It actually, those first 1,000 days, they determine how far you're gonna go in life, what businesses you're gonna run, In fact, there's argument from the World Economic Forum that the difference between developed countries and the developing ones, or the low and middle income countries, is basically that the healthcare system on the first 1,000 days of life. That's from conception to the second birthday. Now, in South Africa, we start intervening once the child is born. If I was in the ministry, I would do almost similar what Cubans do. Cubans, they look for you if you've got socio-economic problems at home and you happen to be pregnant, but the population in Cuba is more health aware. So they check these things, and pregnancy is captured early. But the Cuban government pulls you out of your family and they put you in a feeding scheme so that when you do give birth, your child is not low birth weight. Because the logic for them is that it costs the government more to bring a child who's born with low birth weight to a normal weight, and they actually complicate. Some of them go to ICU. I can tell you I was trained there, and I haven't seen a low birth weight when I was done with my training in Cuba.
And I think that's the thing about us in South Africa on this high horse where we think we're better because we can do transplants, we can do dialysis, but the major emphasis is preventative medicine, right? So why is it difficult, or there's a lack of understanding of this basic concept that if you intervene early, you prevent strokes, you prevent heart failure, you prevent probably certain cancers, and where you end up spending a lot of money on this. Why is there inertia in the South African health system that says, why don't you go to the communities and implement feeding schemes?
I think for me, the problem is leadership. I think we need a leadership that firstly embraces the public-private sector system, because that's the reality of South Africa. But leadership that is almost ready to learn and leverage because they've got pros and cons on both sides. And if we talk about preventive medicine in the private sector, I mean, the Discovery program, the Vitality program is basically primary health care.
Yes.
That's primary health care, basically.
Yeah.
Okay? Because we're preventing you from getting sick, but that's a profit-driven and a business model for discovery. But that model works in the public sector perfectly. So we as a country, I think we have not taken a step back and just to say 80% of the problems that we have in healthcare could be solved by a system that is efficient and looks at preventing South Africans from getting sick than curing them when they are sick. Because it's also not, I don't want to say cheaper, but it's more
cost-effective
to actually prevent people from getting sick. And I think that's what we have not done well. Even when we go and benchmark, I mean, the same maternal concept that Cubans do, South Africans were there. They were told about maternal feeding homes. But when they got here in South Africa, they made them waiting homes in hospitals. So our view of a health system is that it must be institutionalized. So we don't want to put it where people are at the community. And I mean, one of the things that made me to actually fall in love with your hometown, Durban, besides the weather, was I think you were one of the first, Durban was one of the first cities to have those outside gyms.
Yes, yeah.
You know, for me, that's the kind of, because every rand we spend in this health system is not an expenditure that is, it's almost like an investment to the people of the country. Countries that thrive are countries that have very good health systems. Now, if you want your country to thrive, your people have to be healthy.
Yeah. You know? Now, this inertia from the government to implement primary healthcare as the primary goal, and obviously reduce the issues of financial burden. Why does it happen? Do people in government not willing to do, unable to do? And I'm going to put you in the spotlight. So if you're to run ministry, do you think you will lose focus because of the political landscape of South Africa? you train in Cuba, you believe in that system. And we all know, even in South Africa, when you're doing public health, that Cuba's got one of the best preventative medicine in the world. Why are we not doing it? And before you answer, so I'm framing it, the government looks like there's inertia, or they are not willing, or they are not capable. In doing so, why don't you get pharma industry to get involved? To say, look, this is South Africa. If you are Pfizer, if you are GlaxoSmithKline, you come into South Africa, we need you to do X, Y, and Z to help us with the primary healthcare system. We should be talking to conglomerates, mining companies that have benefited hugely in South Africa. Petroleum, say, look, can you help us? But I guess the most important thing is the government itself to show the willingness. Why is it so difficult, Doc? Why is it so difficult?
Look, I wouldn't say it's because they're not capable, but I think it's more, for me, it has to come from a patriotic, I think we must build it from there first, that you must love your people first. And when we love each other as South Africans, healthcare becomes non-negotiable. You know, you should be having doctors. There was something very funny that I saw on the news that doctors in Canada actually were matching that they were being paid, healthcare workers, not doctors, they were being paid a lot of money. They were being paid more.
I know this personally because I trained in Canada. And I remember so 2017, I was going to immigrate, and my daughter just started school in boarding school, and she was not mentally doing well, with the changes. So I decided not to go. But I'd done about 15 interviews. And these guys were like, you have a private sector doctors who never work in government. They were like, it cannot be. How can you not, they didn't use the word, but basically not love your people?
So for me, I think it has to come from there. But again, you also need to, I think there's a trust deficit between the public and the private sector. That's number one. Number two, there's also trust deficit between the health professionals in general and the state. And for me, the important thing is to build that trust first. When we tried yesterday, we were sitting with the minister and we were saying, we, as SAMA, there is no way we exist to unite doctors for the health of the nation. The bigger purpose is the health of the nation. So we can't be against universal health coverage. But your model is flawed. And we pointed out why we were saying the model is flawed, the NHI model. And if you remember, if you go back to the green and the white paper, I can remember, I think it was on page 2 of the green and 3 of the white paper. It was clear there that primary health care was going to be the cornerstone of the NHI.
Yeah.
We've shifted focus now. We started focusing on where the money is going to come from. And we explained to the minister that the money is not the problem here. The problem you have is leadership and governance. And that stewardship would be better if people were patriotic and loved the people of South Africa. If we loved each other, the stewardship and governance of that money would be, we would not be having people buying gins.
Doc, you mentioned something that I want to go back badly. Health care should not be negotiable. I think we should come up with a system in South Africa that obviously involve politicians because they're part of government. And the conglomerates and the big pharma. They say, look, you are in South Africa. You can't take the model that works in the UK, India, or somewhere else. This is our situation. But the government should be seen to be doing better. Because at this point in time, even if I have that dollar, it's very difficult to put it into the government because I don't know where it's going. Who's monitoring it? Who's benefiting from it? So all these beautiful things that South Africans have on paper, they don't permeate to longevity, quality life, equality, and it's frustrating, right? So
let me tell you that structurally the minister was very honest, saying that if there's unemployment of doctors in the country, let's just make the recent trend, the person that gets to be blamed is the minister. He was actually making an example about the CEO who was appointed in Free State. You saw that story yesterday. There's a CEO who has a history of defrauding, of having, but was appointed.
Well, there's nothing new in our system, right?
Yeah. So, and it's like, no, but I don't get involved with the appointment of CEOs of hospitals there in the Free State because healthcare is a concurrent function. So I can't, but the story has to have the national minister. So he's saying, but you see, minister, this is exactly what, as an association, we're saying to you. Talk to the sector. Sit down with the sector. Let's create not necessarily an alternative, but a healthcare that works for all South Africans. And that includes business. That includes big pharma. That you can't.
They must conform to what we want, but the government must be professional.
The lead.
And so, do you think maybe if we dissolve national health, not NHI per se, and make it more federal, because we have these national budgets, then we've got provincial budgets, and we don't know where the money gets lost, right? Even if we do, nothing is done about it. Do you think maybe federal states, KZN, Eastern Cape, if they manage their own budget, would be better, or don't think that's not going to work? A federal system whereby KZN is given the money to run and report to the people, rather than health minister says, look, I don't get involved in that. So if you're not getting involved at the lower ground, let's do it ourselves. Do you think that will work?
Okay, so
a federal system.
So that's what we have currently when it comes to healthcare. So there's division of revenue. There's what is called equitable share, which is then given to the provinces. The boss of equitable share is the premier. But then the minister has got conditional grants, which one of the major grants that he's got control of is called the National Tertiary Services Grant. And I think for me, the minister, there are things that are national assets, like the training of medical doctors, and in fact, all healthcare professionals. So let's just give you an example of a medical school in KZN. The dean, that whole institution is under the national minister of education, right? So higher education. But the minute the doctors cross over to the hospital, they now have to report to an MEC. They're now in the provincial, So for me, I think the central hospitals, the teaching centers of South Africa, they have to be treated as national assets. So the availability of specialists in these hospitals, that's a national competence. It cannot be made a provincial competence. The issue of training of doctors according to the country's need, that should be a national competence. It cannot be left to chance. Again, how as a country, as a profession as well, what role do we play on who leads healthcare in the different provinces or let's say the states? No role at all. But the quality, I mean, you would know this. I was not trained undergrad here, but globally, South African trained medical doctors are one of the best.
But it's fading.
Now, it's starting to fail now because you're starting to lose specialists who are now leaving the country or they are going into the private sector. Remember, the private sector doesn't train. Okay, so all of us, we come from the public sector. Now, if that system collapses, if even the accreditation, KZN is one of the worst examples because in fact, the allocation of interns, the junior doctors, is based on how many posts of interns you have accredited on your capacity to train them. The KZN got the lion's share because They have more people. But the province said, no, we can't take this. We don't have the money for them. Send them to some other province. But there's no other province that is accredited as you guys. So just so you know, this is a statutory responsibility. Now you see, internship and ComServe, those are statutory. But the minute you leave and you want to specialize, now the province controls the budget. And I think for me, that's the flaw.
So as of, I think, March 2025, the number purported was 1,800. I think it's gone down a bit, but it's still more than 1,000 young doctors unemployed. So why does a province say we don't want or can't have these interns, can't have these community service doctors? Is it because they don't have the capacity to train them, complete the degree, or they don't have the budget to pay them salaries? Yeah. Is it bureaucracy? So why is that? This is paradox. Because you don't have doctors in the doctor posts, but you've got doctors sitting at home.
Yeah. So they have posts. What they don't have is funding. That's their argument. And they don't understand the health system. So if you've got somebody who doesn't understand the health system running a province, they don't understand what is a registrar to begin with. And they don't understand the funding of the registrar. They don't understand what's an intern, what's a ComServe, the categories of doctors that me and you understand. They don't have an understanding of it. An example
are these the people running this
healthcare in the provinces? Now, we some are partnered with.
It sounds laughable.
It is laughable, but it's sad. We work with National here for the placement of the doctors, the doctors, student doctors who are in med school now. We started as early as Jan last year, and the target was to give them placement by September. There's money, Treasury provided that money. There's accreditation across the country. Now, 520 were being sent to KZN. KZN said they don't have money, but you cannot have money because this is provided for. This is a statutory responsibility for intern doctors.
So where's the bottleneck of this money to get to the junior doctors training programs?
Okay. So let me explain to you what happened. If you don't ring fence the money, when you allocate it, I can show you our 2 letters we wrote to the finance minister and we wrote to the health ministry when this whole thing of the one who are post-ComServes now, that's not statutory. But the 2-year internship and ComServe is statutory. So there's budget for it, okay? So that is allocated, done, because it's the responsibility of the state. Post-ComServe, the doctor is independent. The doctor can go private, the doctor can do, but South Africa is sitting at a 0.35 per thousand in terms of the ratio, doctor-patient ratio. And we spoke to the minister, said, Minister, at least until we get to a ratio that is respectable as a country. The WHO recommends, I think, 1 per 1,000.
Not 0.35.
Not 0.35 is less than half a doctor. So we said to the minister, okay, can we allocate over the medium term money? We needed 2 billion that time, just to be able to absorb what we are producing as a nation, so that we can get to the ratio that is respectable. We agreed with the minister. But when the finance minister announces, the money is not ring-fenced. So it's not a conditional grant. So it's an equitable share. When it gets to a province, it can be used for water, it can be used for potholes, it can be used...
So that's what you mean by ring-fenced. Because I was going to come to that, like, if you are my boss and you say, Brian, I'm giving you $10, I like a bottle of Coke, and I'm giving you that. So I can take that $10 and buy chewing gum.
Yes, basically that's...
And I can act with impunity. There is no consequence, basically.
Well, there should be consequences, but the power, the person who takes action against an emissary who doesn't use allocated finance accordingly is the premier, not the national minister.
You know, I was listening to this person, I think it was Dr. Mzuku, I thought it was you. I don't know her level, but she said something mind-boggling, like, this year I'm not going to employ doctors, I'm going to focus on, I don't know, something else.
Yes.
I'm like, you're not going to employ doctors. You're not going to put soldiers on the ground. When did it become right not to employ doctors? And the precedent has been set whereby when I grew up, there were nursing schools everywhere.
Yeah.
I think what's going to happen with the government, they're going to try and hide behind the thumb. They're going to start training maybe less doctors. So
They've
we
started
seem
already.
to be not having a surplus of doctors.
They've
Because
started
now
already.
they're sitting with this almost 2,000 doctors that are not employable, and it's an egg on their face. I'm afraid that in 20, 30 years, they will just train less and less doctors. So, well, we don't have doctors, right? So it's a precedent that was set with the nurses, and I think it's happening with the doctors. First time I ever heard of an unemployed doctor was 2017.
Yeah.
I was like, no, it's not possible.
It doesn't
in
happen.
SA.
It doesn't happen. Not when you have a doctor-patient ratio. There's less than half a doctor.
Besides that, let's say it was 0.35, but every medical doctor is employed. That's different.
Yes, that's
But now,
that's a different ballgame.
we're still sitting at that number, but then
We
we've
have
got
doctors
almost
at home,
2,000 doctors.
sitting at home. Yeah.
So
I think-
that's ring fencing is the issue.
I think for me, it's management of healthcare. If the responsibility to appoint doctors was sitting somewhere with someone who was responsible, somebody who understands the health system. I mean, for me, each province represents a health system, each province, with Gauteng being the most complex of all of them. Because you've got all the institutions here, or you've got about 5 medical schools in Gauteng, 5 if not 4. And you have someone, it goes back to what we were talking about, that who is running the most complex health system in the country. Now, this is not going to sound very popular, but the first head of department who ran the Western Cape stayed there for almost 19 years. Something must be seriously wrong with you if in 19 years you don't fix things.
Yeah.
But the average time that an HOD can spend, I'm just making an example about Gauteng, is about 2 years. What can you do in 2 years in a complex health system? So we need a...
So where's the bridge now between 19 years and 2 years?
What can you do, honestly? So for me, I think we need a conversation as a country. It goes back to what I was saying, that healthcare is non-negotiable. So we need to sit down with the private sector and say, there are PMBs, okay? And they must be paid in full. How do we structure a system that allows a doctor, a GP to be a gatekeeper and refer accordingly? You know, but how do we also take responsibility for the monies that we collect, right? How do we take responsibility for that? Because remember, as a business, like you were saying, the big mining companies, they've got social corporate responsibility. How do we channel that money into making South Africans healthy so that they can actually do what they want to do or need to do to be entrepreneurial, to do things, to actually work? How do we do that? Like you're saying, you need a government that can be trusted, that's got reliable frameworks for money to come in, you know. And I must be honest with you, for the first time when I was listening to the budget speech by Enoch, the Minister of Finance, I was hopeful for the first time. And I'm not saying at the corner, we've turned, but I was listening, I was like, okay, he's allocated 29 billion over the medium term for the appointment of doctors, and he's mentioning it there. Now, we still need to go and look in the detail. How is that money distributed? Is it ring-fenced?
Who's going to be responsible for this ring fencing of the money? Because I'm sitting here, I'm thinking all these people at different levels of governance, they can do whatever they want. I think it has to come to a point where the president of the country should take direct responsibilities. You can't have a house where your daughter decides to do this with the money and not go to school, and you find out, well, they didn't train. You send them to medical school, but they've been all over the township, and you say, it's okay, next year I'm going to give you money, and next year I'm going to give you money again, without saying, look, we can't do that.
Consequences.
We should be seeing heads rolling. We should be seeing responsibility. And I think the head of state, it becomes so bad. I'm going to give you an example of a Dr. Michaela Houston, who I thought, okay, maybe she doesn't want to work where she's she comes from an urban area. Mm-hmm. So I said to her, look, she was talking about contracts, and I said, no, that's not possible. I think you're lying. It cannot be. And she drove to a place called Bambisana, which is in Eastern Cape.
And no Bambisana very well.
No Bambisana. Apparently it's not even on the GPS.
Yeah, it's not.
Eventually through Shepherds, I'm not lying, and crossing the rivers, she gets to Bambisana, everyone is excited. But they tell her straight, you have a post, but we cannot employ you now because we don't have the money now. And I said, no, man, that's bullshit. But now I'm getting educated that actually such bullshit happens.
Exists. It's there.
You're in Bambisana, small, not even a community hospital.
They need you.
They need you. They tell you we need you.
They have a post.
And the hospital says, yeah, we have a contract. Well, we have a post.
For you.
But we don't have a contract. I said, okay, it doesn't make sense. They have a post but don't have a contract. And then to cap it all, even if you sign a contract, we don't have the money. And she drove back the following day like, that's when I realized I don't understand our healthcare. And I'm thinking,
we're in trouble.
We're talking about national health, and I'm a big proponent of national health system because we can't have private sector giving only to 14% of South Africans transplant, dialysis, all these other things that, by the way, could have prevented using a model in Cuba. Okay, it is what it is. But we can't be talking about national health when you can't fix community service doctors, nurses, healthcare workers, and we've got heads of provinces talking about, I'm not employing doctors this year, but you're in the healthcare system.
Yeah. So, Dr. Brian, that's why you must join this summer before you leave today. Because what you've just said is exactly what we're saying to the minister. To say, minister, you have a problem. And your problem is leadership and governance. Your problem is non-existent human resource strategy. You don't have that. And your problem is infrastructure. Remember, in the past, I think most of the things that South Africa did first were done in the public sector, in big training centers.
Yes, as it should be.
As it should be. Again, I mean, for me, the pipeline of specialists that the country needs. I don't know if you've seen, there's a very good paper that was written by Percept, commissioned by Discovery, that was looking at the kind of specialists that the country will need post-2030. And compare that with the survey that we did at summer when the unemployment of doctors started, with the unemployed doctors, the fields that they would want to go and specialize in. And they can only do that in the state while rendering services in the state. It's like a copy and paste of the needs of the country and what this cohort of doctors want to be trained in. Now, this data, this information for the minister to plan, map out with his colleagues in the premier's offices across the country. Say, but guys, you can't have a health system being managed by non-health people. Yeah. Even the health people who are managing health must be trained with managerial skills.
Like you said, in Cuba, they will, as a doctor, they will teach you how to teach doctors. By virtue of being a doctor doesn't necessarily mean that you're a good teacher. We may be a very good operator, doctor, preventative doctor, but to teach is something different. And we're getting these political appointments that, like you say, if I as a doctor don't understand, like you've taught me today, ring fencing and this and that you can just take this money and do whatever you want. And people are brave enough to, in national radios, to say, I'm not going to employ doctors. I'm going to do this with that money. And they can get away with it.
They can get away.
It's so sad. So I'm just thinking, the national health as a big proponent, how is it going to work when we can't even manage 2,000 doctors? 2,000 doctors were unemployed. But moving along, you touch a big nerve on KZN, born and bred there. Traveled a lot, but born and bred there. I'm in private practice, full-time private practice. Not proud, but happy. Not proud at all. So I was at Nkosi Albert till 2014. And the reason why I left the system was falling apart, but I was feeling maybe sorry for myself because it wasn't working.
Yeah.
And I could go somewhere else. So I'm not proud of that. But so the cardiology department at UKZN cannot train cardiologists because they are not accredited.
Yeah.
You touch on that.
Fell apart.
So I said with them in our meetings, academic meetings, general club, I said, like, I'd like to go back.
Yeah.
My daughter's big now. I can take 1 day off in 5 days.
Sure.
And work there.
Sure.
For free.
And train people.
I said, well, you can't come here for free. I said, you can't employ community service doctors because you don't have money. I'm coming for free. Oh, well, stupid things. Even parking allocation, security.
Okay.
What if you kill a patient, you are not, I said, I've got medical protection. You know, I will tell them that now I'm working in the state. Don't worry about parking, I'll park outside. You know, where there should be potential solution, people see hurdles. I was like, seriously, are you gonna tell me about these things? Just the bullshit bureaucracy.
So imagine somebody who's trained in healthcare first and how systems work, okay? Who's listening to you making that proposal. Different ballgame altogether. Because understands the scarce skill that you are bringing in. In fact, if he's a good negotiator, would negotiate for more than 1 day.
Yes.
Okay?
Yeah. But at least accept 1 day.
Accept 1 day. And
I'll park
also-
outside, it's fine.
Come on.
Tell him about parking. Tell him about
In
access card.
the bigger scheme of things, how does parking fit in here? You're getting a skill that is going to be given to the people of KZN, and all you can think of is parking.
And it's going to make you maybe get accreditation back because
to
the
train.
more because I feel like I work in 2 private hospitals with a total maybe of about 15 cardiologists in a very small catchment area.
Sure.
Now I'm thinking if you were to go to these doctors in private, and most of them are over the age of 40.
Sure.
So they are okay financially.
Sure.
Right. See,
Sure.
you know what? Dr. X, Y, and Z, can you give me
Just
3 hours, not
3
even a
hours.
day. Give me 3 hours and put it on paper that you're going to be there. It will make a difference. But at certain levels, people do not even want to engage in that.
Accreditation by HPCSA comes immediately. To say, we've got specialists that are giving us 3 hours. We even got Dr. Vezi who's giving us the whole day. It's available to train your junior doctor.
It's March next week. I said with them in December, nothing has happened.
I will get in.
Nothing,
You want me to get involved?
Nothing has happened.
I'll get involved. You want me to get involved?
Of course, of course. I mean,
Okay.
like I said, I'm sitting there happy in private practice, but you said something that seems simple. Love yourself, love your people, love your community. How do I sit and work in private practice fully, knowing that doctors are not getting trained? Okay, that's a smaller thing. Patients are not getting service.
The service. They're not getting the service.
And in the doctors who are there, they are stretched to the limit, and the nurses. It's just crazy, and it's so sad for me to be in here. But anyway, go ahead.
So maybe just to give you some hope, so I'm not sure if this is the president now taking responsibility. You know that we've taken government to court on the NHI because we just think it's not workable in its current form. The whole concept of UHC, fully supported as some. And we've given an alternative document. We contributed in developing an alternative document. We've sent it to the president.
So you're not just saying it's not working on the president, though. You're giving them potential solutions.
We've given them a document. The president
potential solutions.
Yes. The ministers got it.
Are they listening to you?
No. For the first time, the minister is starting to listen. So we agreed yesterday with the minister. Agreed in principle. We don't know how it's going to look like. That outside of this whole noise that is being made, now the president, they've said they've paused the NHI up until May. They're awaiting a constitutional court.
Well done.
Yeah.
And I want to say, guys, for our audience, when I say well done, I still want national health because most of our people, black people in particular, are the ones who get the shortest end of the stick.
Yeah.
We need national health.
We do.
people like you in the know-how.
It has to work.
Otherwise, we're going to put billions of rands and it will
we'll
collapse.
Lose them. And we'll lose them. We'll lose them like we've lost
White
the money
elephant.
in Tembisa. I mean, we lost so many billions in Tembisa. It's, that just painful.
And KZN?
The oncology system there. So at least we've agreed with the minister that outside of the big NHI thing, can we look at how do we strengthen health system in South Africa? How do we take control of the training centers so that you don't have this kind of an answer when you are a cardiologist and you're offering your services
for free
to your own people for free? You get an answer like that. So we can talk about that. We agree on that those needs to be managed by people who know what they're doing, okay? So he has agreed on monthly meetings with SAMA just to focus on that one particular thing. And that talks to the funding itself. Because then for those tertiary services, and you call them national tertiary services, the funding must come through national and it must be managed by competent individuals. So we hope...
Not political appointees.
Not political appointees. So that they don't make pronouncements like the ones that they've just made. So at least we've agreed on that. And we are hopeful that we might get some results on that. Because if KZN continues in the trend that it's continuing, it's going to lose the accreditation.
Well, cardiology in UKZN is gone.
It's no longer accredited.
So will be other departments like oncology, neurosurgery, and all of those things. So
that's very sad.
I think the government, if I were to look in the camera and talk to the government, I would say, look, there are a lot of private doctors, fully private.
That can give you hours.
They will give you hours for free. For free.
Yeah.
Talk to them. And like Doc was saying, actually, when I say 1 day or 3 hours, they should be negotiating more because they love their people and they see the potential. So it's extremely sad. On a separate note, though, with this 0.3, it bugs me. 0.35% doctor per 1,000. Do you think, now this is a different topic, it's going to get to a point where we're going to have private medical schools training their own doctors that will then go to private sector? Because I see a lot of grumpy, higher class people saying, well, my doctor couldn't get to medical school because of this and that. And maybe the private sector might take the opportunity to make themselves more profitable without actually serving the country. But because I've got a feeling it's going to be like a private medical school coming up. Yeah. Because they'll say, okay, you know what, you want to go to medical school? Here's a medical school. Well, we'll train you, but you will have to come and work for us. Yeah. It might create opportunity for the young doctors, but I don't think it will feed to the needs of the 86%.
Yeah. So we have to manage that first. That's one of the responsibilities of the profession. Already we've been approached by private players. So I know HASA, the Hospital Association of South Africa, is leading this. But their approach is slightly different because the training still needs to be driven by state. But it's almost like the same spirit of the RWAP's policy that says, yes, you work in the state, but you get exposure in the private sector because of possible the latest technology that these companies can afford, which we should have in the state, But you get to use the different toys. Now, that conversation is stalling because the leader is not, the state is not there. Government has to lead that. The accreditation of these private hospitals as training centers, because that's what HASA is pushing. It's not pushing for a medical school, but accreditation of private hospitals as training centers for doctors. I know that one of our subsidiaries, SAM, is actually pushing for a private medical school. And from a legislative framework, it's a minefield. It's very difficult to go through. So,
like NHI?
Yeah. I mean, it's even worse because there's a lot of hoops that you have to go through, even to start. There's one in Eastern Cape that started just 2-3 years ago in PE, the medical school. They had to jump the legislative framework. But I mean, for a country like South Africa, with let's say 60, 65 million, if we count everybody who's here. 10 medical schools were really not, I mean, and I think that's what gave birth to the Cuban program. They have started shutting down the Cuban program. It's scaling down now. I think we've got less than 300 students left.
And why is that? I mean, if you quickly touch on that.
I think it's actually one of the, there are medical schools now that are additional to the ones that we had when it started. Like the PE one, Northwest is applying. We were in Northwest launching the medical school there. So you're starting to see medical schools in South Africa. So you don't.
So you're creating our own medical school.
Yes, our own, and that's the best. I mean, the disease profile is different, like I was saying. So they've scaled down, but I also think it fits what we're saying, that they're starting to see the pressure of they're doing what you were saying, that okay, because the Cuban program was scaled up massively at some point. So they were sending thousands. During our time, it was just 10 per province. So they've started scaling that down. Now, if you ask me about private medical schools, I agree with you that we would have to tread very carefully there, because the purpose must always be based on that love for the nation, not profit per se. We want to have money, we want to live comfortably. Private sector is profit-driven. There's nothing wrong with that. There's nothing wrong with that. But there's a phenomenon that is happening at the registrar level when someone wants to be a specialist. The government currently has posts of registrars accredited by the HPCSA across the country. But the provinces do not have money to pay those doctors for the period of 5 years as contract doctors who are being trained. Now, in the past, I think mainly in KZN, you had what we call supernumerary registrars. They would be funded by their countries. So they come in an agreement with...
And there was a lot of Libyans at some point.
Libyans, yes. Now, that is starting to mushroom in South Africa, and that's something that we as a profession need to look at, that those who have the money. So if I'm part of the group that is unemployed, right? But I'm from a family that is well-to-do. I don't need the salary for the 4 years. So I can go into DEM, I can go into radiology, I can go into cardiology, I can go into the Percept paper and look at what is scarce skill, and even use other global sources of information, and go into that post in UCT and sign, I'm a South African, but get a supernumerary post.
So a declaration to say, look, I will not take from your coffers.
But I need a training number, I need access.
Because it will relieve some of the debate. We spoke passionately about community service doctors. Internship, where you said it's a structural responsibility for those doctors. But once they're beyond that, some of them don't want to maybe to go straight to specialize, which is fine. You can go to family medicine, general practitioner. But what about those who want to specialize? You know, so I think it's not a bad idea.
70% of them.
It's not a bad idea to say Netcare, Discovery, LandMed, all these big groups to say, like, we can help us train these people.
No, but that's why I'm saying you must join the association. You can't leave without joining the association. Because we've had those conversations directly with Discovery. You know that they have a Discovery Foundation.
Well, I was one of the first recipients. In 2000, thanks to Bongani Mayosi. 2006, and I went to Canada on a Discovery Foundation. And I said to myself, I'm going to come back home. And I did. But through programs, high school, we spoke about Shell. For me, it gave me a pedestal. So I'll forever be grateful to those people who show initiative. Discovery was huge for me to train in electrophysiology overseas. But just sitting here, I'm sad and happy. Sad because of the state and the way you've just explained make me sad that it doesn't seem to be difficult. To me, it seems like there's nature from the government to say...
It's not difficult.
Well, take responsibility. I've given you money. but you've taken that money and fixed potholes, and you're saying you're not going to employ doctors.
And if you lose the pipeline of specialist training, it's going to affect even the private sector, the system itself.
I'm not even concerned about specialists. Not concerned. Less concerned. I'm just talking about let them train. Let them be doctors.
Allow them to train.
Yeah. Just get them community service. Get them internship.
Get them register posts.
Yeah.
Why can't you do that?
I think you've sold me on the concept of SAMA. I think in the next 7 minutes, I'm going to be a member of the South African Medical Association because on a very serious note, okay, part of it is exposure. You spoke about the exposure, and exposure works at many different levels. You went to Cuba and, what you saw there. So exposure to these discussions where, personally, I'd forgotten about SAMA. But now sitting with you and listening to that podcast by Dr. Mzugo, I was like, we need to do something.
Yeah,
for me, not to be able to go to public sector because I can't get a parking or access card.
Come on.
What if the patient dies? Why don't you leave that to me? And those are peripheries. Their core issues is that
patient.
the patients.
So no, I think I'm happy. It takes 4 minutes, by the way.
It takes 4 minutes.
Yeah, online.
So
to become a SAMA member. So you don't need 7.
Hopefully, we'll talk again. But personally, the biggest thing today for me was how Doc analyzed the political situation in healthcare.
Yeah.
Sad, but also it made me feel better in a way that if we know our problems, I think we've got potential solutions. Like they're not shutting down NHI, they're not shutting down training of the doctors, but say you can't be doing this and expect this. You keep doing the same thing every year. You have this budget that doesn't permeate to the people. Please, government, engage people like SAMA, people like private doctors, conglomerates, LandMed, Discovery. And I think some of them are willing to do it. But those who aren't willing, they need to conform. For them to do business in South Africa, they need to conform. But I think it starts with, let's be clear, it starts with the government.
Yeah.
And thank you very much today, Doc.
Thank you to you, and I enjoyed this. Thank you so much.
Please invite me again. I know you're my guest, but I'm kind of like invited by you.
Sure.
And I want to thank Mashimane, Creative Replay. So today, I think it was, personally, I learned so much from South African Medical Association CEO. He is a CEO. He's a physician. Pilot.
Okay, no, I didn't get
Almost. Almost a pilot. Public health. Guru. Wait, before I close down, I saw something. Didn't you do some postgrad at Rhodes?
Yeah, so I went back.
Yes.
So I did my master's in business at Rhodes. So
Yes,
I've got
MBA.
an MBA from Rhodes.
Yeah, because I saw that.
Yes,
so I wanted to touch on that. You have one on them because you came back.
Yeah, I went back
and did your postgrad.
I told them when I was graduating that I've got one on you.
Yeah, one on it. No, thank you very much, Doc.